Well, hello everybody. My name's Jake Bauer. I'm going to be doing these anxiety lecture and your mood lectures. So, just a little bit about me, just so you kind of have an idea. I've worked in peds for about 10 years before I transitioned into psychiatry. Got that, and now I do psychiatry where I work with children and adults. And I think children, just as a whole, create just kind of a difficult sometimes and just an interesting, different population to treat. I would say that, one thing in peds that they always remind us is that, kids aren't just little adults. They come with their unique set of differences and difficulties sometimes, and their joys also. And I think too, just the hard thing about treating kids that makes difficult is that they're not in control of a lot of things. So a lot of times you'll have parents or guardians, and you can sit there in the room and almost think, well, the reason this child is probably suffering is because of you, or the things you're doing. And of course we don't say that, or I would encourage you not to. We try and offer little helpful hope pieces, point them in the right direction, maybe offer resources, books. It's also why I think that a lot of times a good therapist is really beneficial to a child, just because they help give the child tools, they can help give parents tools. And I say a good therapist, I don't mean in a bad way. There are therapists that aren't as good or maybe aren't as well versed with working with children, just like there are practitioners that aren't as good as what we do. Or, I have my weaknesses and areas I'm like, you would not want me to help you with this, and things that I think I'm better at, as we all do. So, and I'll also tell you this, and this could be the one intro, so that don't worry, the next lecture should be a little bit easier and shorter. Every test question that I wrote for you guys on these sections comes straight from these notes, this lecture that I wrote. I also have provided it for you, where I put all the kind of bullet points. So everything will come from these pages. So that should be helpful. You don't have to feel like, where do I go? But I would always encourage you to read either journal articles given, book chapters, just read things to help give you a little bit maybe deeper perspective, or help for areas that maybe you don't feel like you quite grasp or understand as well. So I hope this feels helpful and beneficial. I hope this doesn't feel like a waste of anyone's time. I want you guys to actually learn. The more that we learn, then the better that we can serve those around us. I tell my own children all the time that practice makes preparedness. So, the more we're practicing, the more we're trying to push ourselves to learn better, then the more prepared we are when a young child walks into our room and we're the one there to help. I think too that that's just what makes, to me, psychiatry a difference. When I worked in peds, I wasn't the specialist, right? I was the general pediatric practitioner. So if I found, an issue or something raised a flag, then I could refer them to the specialist. What makes this interesting to me is when they walk into us, we are that specialist now. We're the person they maybe have been referred to. And so we now are the ones that are trying to help and find those answers. We can always ask others for help beyond us, but people really look at us now as, you're the specialist, you're the one that's here to help me. So okay, well, that was probably enough intro. Sorry for wasting your 4 minutes, and let's just go ahead and start with just anxiety disorders in children. So just thinking about how often this is, the CDC says that about 9% children's age 3 to 17 has been diagnosed with anxiety disorder. Anywhere from over 31% ages 13 to 18 affected by anxiety disorders. These are individuals are at higher risk to perform poorly in school. They're going to miss out on important experiences. They're more likely to use substance use. So, having an anxiety disorder is going to create things to be difficult for them. Anxiety disorders are the most common of all mental health disorders. So This happens a lot. You know, a lot of individuals are going to be struggling with anxiety. There are some things that can help with anxiety disorders, screenings. There's the SCARED, which is I believe it's 27 questions. You're not going to be tested on that. I think it's 27 questions. I would look at it to make sure. And basically that is going to kind of then break down after you score it, like, you're struggling with separation anxiety, you're struggling with social anxiety disorder. Then there's the GAD-7, generalized anxiety disorder. It's a 7-question questionnaire. It's for ages 11 to adult. The SCARED is for ages 8 to 18. And again, just remember, these screenings are not diagnostic, right? So this does not diagnose you with generalized anxiety or even with separation anxiety. It is a screening to say, hey, look at this. There's a good possibility that this is a struggle for them. So generalized anxiety disorders, what does this mean? In kids, they're going to be worrying about a variety of different things, kind of everything all the time. The thing with anxiety, right, it's not something that we can turn off and on. It's not stop worrying and then it goes away. It kind of feels like it's always there, all consuming. Now with kids, they kind of will worry about kid things, right? So maybe grades, friendships, social relationships, am I athletic ability? How am I doing in school? Maybe family issues as well. Mom and dad gonna fight. They've been arguing. I don't have food in the cupboards. Those type of issues. With kids especially, they might not be able to articulate that I'm worrying, I'm scared about something, my mind's racing, my thoughts don't ever turn off. They might kind of just have physical complaints, somatic, oh, my belly hurts all the time. Oh, I have a headache. Oh, these may be kids that are going to the school nurse multiple times a day. They also can act out a lot, right? So they may just get in trouble more at school. They may have a little bit more behavioral issues. It'll affect their sleep usually, right? So they may wake up often. They may not be able to fall asleep at night. So kids can then also just be overly conforming, perfectionists, redo tasks just because they're always worried they're going to be making a mistake. Always wanting somebody to remind them, hey, yes, you're doing a good job. Oh, you did so well on that. So that's kind of the typical presentation that we may see. The DSM-5 criteria: excessive anxiety, worry more days than not for at least 6 months. Variety of activities, may find it difficult to control the worry. Anxiety and worry associated with at least one of the following items: restlessness, edginess, fatigue, difficult to concentrate, mind going blank, irritable, muscle tension, sleep disturbance. It's going to be causing them distress either in relationships or school or at home. Of course, then these are always the big ones. So you'll see this on every single diagnosis, it feels like, in the DSM-5. Not attributed to a substance use or a different medical condition and cannot be better explained by another mental illness or disorder. So that, I would say, is on every single DSM-5 diagnosis. Cannot be one of those two things. So things to also think about: different anxiety disorders, obsessive compulsive disorder, ADHD, PTSD, and of course then comorbidities with the generalized anxiety disorder are other anxiety disorders and major depressive disorder. And just something to bring up, I think the book makes mention of this, right? What do you do? I mean, okay, so the DSM-5 is at least 6 months. If a kid comes into you and for the last 4 months they've been worried, they're meeting all these criteria, things have been difficult, are we going to say, oh no, they're not struggling with anxiety? I guess technically we could find a different diagnosis, anxiety other, but it's anxiety disorder, so we're still going to have to really help them similar ways. Okay, so separation anxiety disorder: anxiety that's going to appear when a patient is separated from their parent or caregiver, or at the thought of or possibility of being separated. Often it's going to really inhibit these kids in school, right? Because this is where they're going to be going all the time, or with babysitters or daycare, or being left at home with their older siblings. It could have a precipitating event: move, illness, surgery, loss of friend, pet, accident, bullying even. Some studies have shown that Persistent bullying can have similar effects on children as adult traumatic settings. So think first responders, veterans, healthcare workers. Bullying is a big deal. And when kids have to go into school every day, I mean, that's a traumatic event happening over and over and over and over again to them. So children and adolescents especially vulnerable for separation anxiety at 3 different stages. When they begin kindergarten, so at 5, 6 years old, when they're shifting to more complex peer relationships, so about 11 or 12, and when they start puberty around 13 to 14. So we do have to think that these are the ages that these events are usually happening, but if a young girl could start puberty at 8 or 9 years old, she may start going separation anxiety because she's starting puberty. There's often a regression of behavior. Previous adolescent who was independent may now need to be near their parents all the time, right? So again, a regression back to something. The DSM-5 criteria here: developmentally inappropriate excessive fear, anxiety concerning separation from those the individual is attached to by at least 3 of the following: recurrent distress when anticipating or experiencing the separation, persistent worry about losing major attachment figure or being harmed, persistent worry about experiencing an event that causes separation from a major attachment figure, refusal to go out because of fear of separation, persistent fear of being alone, persistent reluctance to sleep away from home or away from the figure, repeated nightmares involved separation, repeated physical symptoms, persistent for at least 4 weeks in kids, causes significant distress in life, and then, of course, cannot be contributed to the other things. The differential diagnoses: other anxiety disorders, panic disorder, social anxiety disorder, PTSD, also comorbid with other anxiety disorders and mood disorders. So remember, separation anxiety, the big one here is they're really afraid of being separated from some individual. And either from being separated from it causes them distress, or even just the thought of it happening. Social anxiety disorder in kids results from them having a fear of scrutiny from others. So often feel they're being judged, ridiculed, difficulty speaking up in class, asking for help, going to parties, social gatherings, any sort of performance. These kids will be in their mind all the time. What is something going to happen to me? I'm going to do something embarrassing. Somebody's going to make fun of me. Usually begins in the preteen years, become chronic, persisting into adulthood. Children do not have friends as adults, do not marry often, can develop substance use disorders and depressive disorders. Children will often lack self-confidence, inappropriately timid for their age, perform poorly in school, avoid situation with other peers. Children must have social difficulties with peers, not just adults. So again, these kids can't just be shy, scared around adults, but then interact really well with people their own age all the time. They're gonna not want to be in the situations with peers and with adults as well. Major difference between agoraphobia, right, and social anxiety disorder is the motivation and the root of the anxiety. So in agoraphobia, individuals avoid the social situations because they don't like feeling the anxiety. It's not that they are scared everyone's looking at them, judging them, what if they do something embarrassed. It's just they feel anxious in those moments, and so they don't want to go there because they feel anxious and they want to avoid feeling anxious. In social anxiety disorder, the individual is avoiding the situation due to fear of embarrassment, being judged, ridiculed, what people think of them, how they're going to mess up. The DSM-5 criteria: marked fear, anxiety in social situations in which the individual is exposed to possible scrutiny of others. And children must occur in peer settings, not with only adults. Individual fears they will act in embarrassing or humiliating manners. Social situations almost always promote fear or anxiety. Again, this can be kind of somatic symptoms in children. Social situations are avoided or endured with intense fear anxiety. The fear anxiety is out of proportion to the context. The fear anxiety or avoidance is persistent and lasting 6 months or more, not attributed to another medical condition or physiological substance, not explained by another mental health disorder, it's not related to another medical condition. Again, differential is going to be all these other anxiety disorders, comorbid anxiety disorders, and major depressive disorder. Panic disorder. A lot of times when we're doing interviews, and I even get guilty of this, I'll ask individuals, have you ever had a panic attack? No, I haven't had a panic attack, but I've had these anxiety attacks. And so then we talk about them. And they really feel like, yes, I'm trying to describe to you the same thing. A panic attack, anxiety attack. So what this is, recurrent unexpected panic attack can last seconds to minutes, come from a state of anxiety or an unanxious state. During the panic attack, 4 or more of the following symptoms are present: palpitations, sweating, trembling, sensations of shortness of breath, feeling of choking, chest pain, nausea, feeling dizzy, lightheaded, chills, heat sensations, numbness, tingling sensations. Can have some derealization or depersonalization, fear of losing control or going crazy, fear of dying. At least one of the panic attacks has been followed by 1 month or more of one of the following: persistent concerns or worry about additional panic attacks, or significant maladaptive change in behavior related to the attack. So have, again, this sort of agoraphobia could come in. Some people just get anxious, but if you've had a panic attack, then you're going to start avoiding going out to public places because you want to avoid that panic attack. Cannot be attributed to other substances, illnesses, or mental health. Panic attacks and a diagnosis of panic disorder within the last 12 months are related to a higher rate of suicide and suicidal ideation, often comorbid with other panic or anxiety disorders, depression, bipolar, and even variety of other health disorders, respiratory, cardiac, GI disorders. If you're going to feel those actual other health disorders, you may also then have panic attacks. Selective mutism. This is one that really is only going to be noticed in children. Children that struggle with selective mutism have normal development, vocabulary, and speech pattern skills. They will talk regularly at home or with individuals they are familiar with, but will fail to speak at school or with strangers, including therapists, which can make treatment frustrating. These children will often have normal intelligent levels. When they do speak, their speech patterns are normal. So, individual with developmental delay, right? They are having trouble speaking at home. They are not using words. Maybe they're not forming sentences. These kids can speak regularly at home or in these situations they're comfortable in, but then when they get to school or other situations, they won't say a thing. Consistent failure to speak in certain social situations, although they speak normally in other situations, it lasts at least a month, interferes with social, occupational, or educational environments. The failure to speak is not attributable to lack of knowledge or comfort with spoken language. The disturbance is not better explained by communication disorder and does not occur exclusively during the course of another mental illness. These kids can come across as overly shy or anxious. They may have tantrums, exhibit oppositional behavior, be clingy, compulsive traits, socially isolated because they're not talking. Comorbidities, of course, anxiety disorders, and phobias. Obsessive compulsive disorders. Obsessive compulsive disorders can be found in up to 2% of all children and teenagers. Could be more common in most children and teens because they don't report this disorder. They're not going to, talk about the things that often are just going on in their mind. Most often, individuals experience compulsions more often than obsessions. Often the compulsions can carry a small amount of pleasure and also help relieve stress or tensions that are being felt by the individual. They are often done to relieve stressors, and it can be difficult for the individual to control the behavior. So the DSM-5, presence of obsessions, compulsions, or both. Obsessions are the recurrent and persistent thoughts that feel unwanted, intrusive, and they're causing anxiety or distress. They try to ignore the thoughts or neutralize them with the compulsion. Compulsions are repetitive behaviors or mental acts that an individual feels driven to perform in order to neutralize the obsession. The behaviors are aimed to neutralize or reduce anxiety or distress. However, they're not connected in a realistic way to the problem they are attempting to neutralize. Children may not be able to articulate the aims of these behaviors or acts. So, this is where an individual is scared someone's going to, that they forgot to turn off the stove, so they're in there all the time. That's not going to help relieve the other anxious thoughts. They don't know why they keep going to check the stove. The obsessive compulsions, they're time-consuming, take away from other needed activities, cannot be attributed to other substance, medical condition, or mental health disorder. So then we need to specify the insight: good or fair, poor or absent delusional beliefs. specify if a tic order is present. So 30% of individuals with OCD have a lifetime tic disorder. This is more common in males with onset of OCD in childhood. Remember that obsessions are repetitive and persistent thoughts. They are not pleasurable to the individuals. They are unwanted. So they don't want to be having these thoughts in their mind all the time. They're causing them distress. They're causing them anxiety. They try to ignore them, suppress it, neutralize it, but it's not helping. The compulsions are the behaviors to help neutralize that stress of the obsession. Ritualistic must be performed until things feel just right. They are not done for pleasure, but relief is often felt after they are performed. Males have an earlier age of onset. 25% of cases start by age 14. Compulsions are more easily diagnosed in children because they are easily observed, but they often are suffering from obsessions as well. OCD can cause distress in life and in relationships. Children, adolescents can suffer developmentally. Remember, we want to think about the Erikson and Piaget stages of development. How can, maybe these anxiety or OCD disorders affect that, right? If they don't make it to the next developmental stage, or they kind of get trapped, then what kind of struggle are they going to have? Obsessive compulsive personality disorder is different, that the individual's driven to perfectionism and rigid control that interferes with life. They are not driven by pattern obsessive thoughts and compulsive actions to neutralize those thoughts. You can't have both, but remember, OCD personality, these are the people that's just like, I just have to have everything perfect. I just like things my way. I want to be the best. I want to be perfect. I'm going to obsess over it until I get it perfect. So they're driven to this perfectionism. It's not a anxiety thought that they don't want that then is driving them to compulsions. So you can't have both, but that is a little bit different between that personality disorder and then an OCD disorder. Body dysmorphic disorder. So individuals obsessed or preoccupied with parts of their body or appearance they believe to be defected or flawed. They believe these defects are ugly, deformed, abnormal. Often these things, others don't see them, or it's like, okay, I can see it a little bit, but individuals suffering with this, it is kind of overwhelming them. These preoccupations, they're intrusive. They don't want them. They're time consuming. They can't ignore them. They can't resist it. They're going to be driven to perform mental or behavioral acts to neutralize these thoughts. They may consistently compare themselves to others, check themselves in the mirrors, try to hide the flaws, excessive grooming, always seeking reassurance. They could be obsessed with exercise, weightlifting, or frequently look into cosmetic procedures. The preoccupation is causing distress in their daily lives. It must be differentiated from an eating disorder. So there's a difference between body dysmorphic disorder and an eating disorder. Muscle dysmorphia is a form of body dysmorphia that is a preoccupation with the idea that one's body is too small, lean, or does not have enough muscle. It's almost exclusive to males. Behavior is almost always influenced with dieting, exercise, and or weightlifting. Often individuals injure themselves because they're pushing it too hard. And often these individuals are normal or kind of normal muscular in appearance. But they can also be then driven to anabolic steroids, other substances to increase muscle growth. Often their insight is poor, delusional, right? So with insight, they do not believe that they are wrong. They believe it is really there. Same insight parameters described in OCD: good, fair, poor, delusional. Most common age of onset in body dysmorphia is 12 to 13. Individuals with onset before age 18 are more likely to commit suicide. So these are distressing to people. Males are more likely to have genital preoccupation than females. Females more likely to have a comorbid eating disorder. Often causes severe impairment in functioning. High number of adolescents, adults have been hospitalized with these. 20% of youth report dropping out of school due to their body dysmorphia. Some individuals may be homebound due to this disorder. They just can't go out because they cannot stand this flaw or this, part of them that's deformed in their mind. Differential diagnoses, of course, other anxiety disorders, eating disorders, major depressive disorders, the most common comorbid disorder with onset usually after the body dysmorphia. So body dysmorphia starts, and then it's kind of, once that takes over, then they kind of can fall easily into a depression. Trichotillomania and excoriation, we'll kind of do these the same because really just the major difference is, are they pulling hair or are they picking skin? The two disorders similar, main difference area of the picking and pulling. So the trichotillomania, they'll pull out hair, and excoriation, the individual's picking at the skin. Both disorders consist of the recurrent urge to pick hair, skin. In excoriation disorder, the skin picking results in skin lesions. They may make efforts to stop the behavior, of course not better described by anything else. The hair pulling can be for brief periods, so they may just do it every night when they're in bed, or all kind of day long. Extended periods can continue for hours. Most common sites are the scalps, the eyebrows, and the eyelashes, the eyelids. There may be specific rituals with the hair. They may roll it between their fingers, looking at it. They could swallow it, the hair. It could be caused by boredom, anxiety, distress. Often does not occur in the presence of individuals other than family members. So they can often know, like, I probably shouldn't be doing this, so they do it in the places they feel safest. Pain usually is not coming with the hair pulling. In children, the prevalence is equal between males and females. With the hair pulling, we need to always be aware that swallowing of the hair can result in a trichlobazar, which is basically like a large growth. They could get really anemic. They could have abdominal pain, nausea, vomiting. Then it could develop into a bowel obstruction and then a perforation. So something to be aware of in these individuals may be to make sure they're not swallowing the hair. Differential diagnoses, of course, other OCD and anxiety disorders, often comorbid with depression. Excoriation is usually going to be face, arms, hands. They can pick at healthy skin or just little minor scabs. They just can't leave it alone. They could use their fingers, but they also may use tweezers or other objects to pick at the skin. Can result in infections, requiring antibiotic surgeries. Usually the excoriation begins in teen years with development of puberty and acne. 3/4 or more of individuals affected are female. That's with the excoriation. Okay, so those are the major anxiety disorders. There's other ones. These are kind of the ones that are mostly in our book. These are what you will see mostly with children and adolescents. So then it's kind of like it's to, okay, what do we do about it? The number one treatment option for children and adolescents suffering from anxiety or OCD disorders is therapy. So again, especially with kids, right? These are new disorders. So if we can help give them the tools, the way to retrain our thoughts, then we can really help set them up for success moving forward. Of course, the combined treatment option of psychotherapy, family patient education, pharmaceutical medication if needed, is found to provide the most optimal results. So really want to get these kids in therapy. Therapy and medication is going to give us the best results. SSRIs have been shown to be most effective in children and adolescents. They are the most recommended drug of choice for pediatric anxiety disorders. So common side effects of SSRIs: GI effects, nausea, vomiting, diarrhea, heartburn. These can usually get better. Some children may gain weight, some may lose weight. Can also have behavioral activation. So this is different than the hypomanic manic episode, kind of throwing someone into bipolar. This is just an altered mood, or they're irritable, agitated, restless. Can occur when we increase the dose or initial dose. Can happen in the first few days or weeks. We can switch to a manic hypomanic episode, so that's why I definitely want to stop if this starts to occur. These are often new symptoms in the patient, usually occur months after initiating treatment, and may not abate after discontinuing the SSRI. That's if they switch to the manic hypomanic episode. It's important to conduct a thorough family history of bipolar disorder. So remember, bipolar disorder has a huge genetic component, so that's why we ask, are there any other mental health illnesses in your family? Sometimes people don't know, so you may ask questions like, yeah, I mean, because a lot of mental health's taboo, so we didn't really talk about that. Okay, I ask sometimes, did anyone have to be in an inpatient facility, or was there ever talk of, your grandmother, really struggles? So really want to kind of screen for a family history of bipolar disorder. Serotonin syndrome is an emergency situation, consists of agitation, confusion, sweating, hypertension, fever, myoclonus, hyperreflexia, tremors, diarrhea, tachycardia, These people are kind of moving all over the place. They're hot, they're sick. If symptoms are noticed at all, then the serotonin medication needs to be stopped, general medical care provided. So discontinuation syndrome occurs when we stop our medication abruptly or lower too quickly. Often happens with meds of a shorter half-life, so Paxil. Long duration of use, so the longer you're on it, the more likely you're going to have discontinuation syndrome if we stop them too quickly. These kind of think flu-like symptoms: GI upset, irritable headache, sweating, maybe agitated, fatigue. Symptoms usually seen within 2 to 5 days. Fluoxetine has that very long half-life, so it can be 7 to 10 days later if that one is stopped abruptly. Symptoms usually resolve within a couple of weeks. May need to start the medicine at a lower dose and do a slow taper instead. Okay, so the black box warning, right? The suicidal ideation. A study in the 2004 by the FDA issued a warning that children and adolescents being treated with antidepressants be monitored for increased risk of suicidality. Multiple studies have not really been able to confirm this, but it's there. So we have to remember then that we have a duty to tell parents and patients, hey, we need to talk about this. There is this chance. I sometimes tell them that the other flip side that is not on those black box warnings is that once these black box warnings came out, what happened? Providers stopped wanting to write serotonin medications to individuals that felt depressed or maybe were struggling with anxiety disorders. And what did we see? Suicide rates increased. So these medicines for right individuals can have protective factors, but parents still need to know that that is a risk and it can occur. So any moment of feeling, depressed or having suicidal thoughts, the medicine needs to be stopped immediately. Okay, so also a fact, you can have prolonged QT syndrome with higher doses of SSRIs, disturbance of sleep, common side effect. Some children may have daytime sleepiness. Remember, we can always, if they can't sleep at night, so we can always change the dose. Can't sleep, take it in the morning. Make you feel sleepy all day, maybe take it at night. Other possible side effects: loss of libido, increased nighttime sweating, apathy syndrome, right? I just don't feel anything. Increased bleeding, could have mammoplasia or gynecomastia in a male or a mammoplasia in a female. Black box warning we talked about, that we have the duty. Considering the use of an antidepressants for any clinical use must balance the risk of the increased suicidality. Patients who are started on therapy should be observed closely for clinical worsening, suicidality, or unusual changes. Caregivers should be advised of these. Increased risk of adverse effects in children who are significantly underweight, underlying hepatic renal disease, history of daytime sleepiness, and tachycardia conduction disorders. So behavioral modalities, though, are still the mainstay of treatment in children and adolescents, so those therapy techniques. If symptoms warrant medication or therapy is not able to be started, then SSRI is the drug of choice. Numerous studies point to possibly needing doses that are higher than what is needed to treat depression, may need treatment longer when treating anxiety disorders. No studies have shown a superiority of one SSRI over another. Treatment should be continued for at least 1 year. When discontinued, patients should continue to be monitored for reemergence of symptoms. Once started, should be continued for 4 weeks before thinking of a dose increase or switching meds. So remember that 4 to 6 weeks, at least 4 weeks. Due to the higher rates of metabolism in children and adolescent, BID dosing may help prevent withdrawal effects. FDA, so this is how they advise that we should check these kids. Followed every week for the first month, every 2 weeks for the second month of treatment, and at the end of the third month. So 2 weeks for a month, every week for a month, every 2 weeks for the second month, and then at the end of the third. There's other meds sometimes used: SNRIs, mirtazapine, buspirone, propranolol, hydroxyzine, benzodiazepines. The SNRIs have side effects similar to SSRIs, although they have the bigger possibility of raising blood pressure and increased sweating. So high caution in children that have history of seizures or recent cardiovascular or cerebrovascular event. We should probably not use the SNRI. We do not want to kind of cause any other issues with that. The mirtazapine, nifazodone, they're rarely used. They can be highly sedating, high weight gain. Not much data showing that they're more positive than the other meds. Buspirone can be great, has mild side effects, headaches, dizziness, nervousness, no proof of dependence or significant withdrawal. It's rapidly absorbed, reaches peak level in about 40 to 90 minutes, can take up to 3 weeks for optimal improvement. It can increase risk of serotonin syndrome when used with SSRIs, but it can be a good adjunct for anxiety and can be effective on its own as well. Propranolol, not well established, can cause dizziness, fatigue, hypotension, GI upset, contraindicated in children and adolescents with sinus bradycardia or heart failure or asthma. Has been shown to be helpful in certain specific situations such as performance anxiety or competition anxiety. May need to monitor some labs with that. Hydroxyzine, not really recommended in treatment of anxiety disorders in children and adolescents. Benzodiazepines do not have sufficient evidence for their use in anxiety disorder in children and adolescents. So, some helpful strategies with kids. I'd say time of day to take meds is not as important as consistency, right? Who cares if they take it every night or every morning? If best time for them to remember to take their meds at 3 o'clock in the afternoon, then take it at 3 o'clock in the afternoon. But the consistency matters more than the time of day. Another one that can be helpful, Prozac. Remember, it has that really longer half-life. So, certain kids or families that maybe they have a hard time remembering their meds, right? Oh man, I kind of forget to take my med every day. I maybe do it every other day. Then Prozac may be a really good choice because, well, that's okay, because you're going to have this in your system longer. So that may be helpful to use for kids that have a hard time remembering. There's a handout that I gave that talks about these different meds. These kind of all go through doses. It kind of gives you the, age range. So, what we're always wanting to do is best practice at all times, but sometimes our hands are tied, right? You tell a parent, hey, this SSRI has a black box warning. Oh no, I won't take that. Okay, I want to try and give you some help, so maybe we try hydroxyzine. We can know, I don't know how helpful this is going to be. It could be fatigue, but I think it's also important for us to always remember the placebo effect of these meds on individuals, right? So, the placebo effect, it's like a 40% of individuals that take the placebo are like, hey, I think my depression or anxiety is improving. So it's, of course, we're always balancing the risk and the reward. So if they don't want to take a medicine that I think this would be most helpful, sometimes saying, hey, this could have some benefit is something we can do. If you read through too, you'll see a lot of these meds don't have a lot of FDA approval for young age. And again, that kind of makes sense. Who's going to sign up a bunch of their kids to do drug studies? And especially if we think of it, it's just anxiety. So again, it's going to be really hard to get a lot of individuals to do these drug studies to get really, really strong data. But empirically, you'll probably work with individuals who, hey, this works for a lot of my patients. I found a lot of success with that. So again, always balance with what our side effects or adverse effects are, mixed with the real world problems of kids who are suffering from anxiety disorders, and then what those kind of can lead to along the way if we don't give them any help at all. So I hope this has felt helpful. Feel free to reach out to me for any questions, and good luck studying and reading up on this, and good luck with treating kids for their anxiety disorders. Have a good one.